Like to thank AIOS and AIOC team and JICE for including me in this interesting session. I'm going to talk about the surgical workflow with new digital technologies in cataract surgery. And definitely that's going to improve the outcome of cataract surgery for us. And that also translate to the outcome for patients also. No financial disclosure from my side regarding this particular presentation. If you look into a workflow, digital workflow in cataract surgery, it has three parts. If three can be aligned or integrated together, definitely the outcome will be better. In a pre-operative assessment, we are looking for, as Dr. Kudlu was talking about, good biometry. IL Master 700 is the ultimate now. Ray tracing aberrometry to assess the aberration profile of a patient, and integrated data transfer which goes to the operation theater in an intraoperative help. In intraoperatively, you have image guided surgery, which gives you access for a better surgical alignment for a toric IOLs, better centration for all types of IOLs. And if you have microscope which has integrated IOCT, which is going to again help you in looking into the dynamic change which happens with each step of surgery can be highlighted and understood better. And over that, if you can do a 3D head stuff surgery, which gives a good advantage beyond the microscope, which has been such a wonderful tool for all of us. In post-op period, I think it's very important to have analysis of these patients, especially multifocal and toric IOLs, by looking for their outcomes. Ray tracing aberrometry will be very, very helpful, especially for toric softwares to assess the alignment and requirement for subsequent corrective measures. Preoperatively, if you can have IL Master 700 ray trace aberrometry data transfer to surgical theater in terms of making surgical precision more accurate for alignment of toric IOLs, that's definitely going to help. I think with swept OCT being attached to a ILMASTER 700, it just gives you a better understanding of total keratometry, where we don't have to really think what is anterior, what is posterior, amount of corneal curvature, and what is going to happen to IOL formula calculation of these patients, because this system includes almost all possible newer generation formulas to help us for a toric and other power calculation for a difficult situation, especially post-refractive surgery patients. And if you have better outcome with toric power calculation, the patient enhancement in terms of outcome, if you look into plus minus 0.5 diopter, increases by further 14%. So that will make things much better for our patient in terms of ultimate outcome. This is talked about by Dr. Kudlu. I'll not go through this, but we can understand if this is total K is with the Barrett Universal or a Barrett Toric or Barrett True K, the things will be better for all types of cases, especially difficult refractive surgery patients. The IL Master 700 interfaces of 5 important areas for integration into digital workflow. Firstly, it can give you a connection to your OR in terms of Ethernet port for a network connection to your printer. So you can get an entire parameter in your hand. And if you have a JICE forum, which will attach various systems, and data can be transferred without requiring the pen drive, which can be sometimes lost and it can have a difficulty. So things become very, very simple in such cases. And computer-assisted digital surgery with Callisto Eye being there. And if you have access to IOCT, that makes also very, very important assessment on the table. So this is what we look into a pre-op phase. If you do a aberrometry for these patients, you can have access to angle kappa, angle alpha. Accordingly, you can decide which case is suitable for toric or multifocal IOLs. And that will decrease the post-op chair time with the patient having glare and halos as such. Intraoperatively, I think that's a major concern for all of us, how we make things easier with image-guided surgeries, and proper toric alignment does require an accurate assessment of the toric axis physically, and getting IOL into the physically in the right space will be much more important for us. Callisto Eye Jet Align is the one which we have been using, and we know that if you have image-guided modalities, the precision and alignment of toric valve is much better, and the outcome is going to be much superior for these patients. Just to highlight a little bit of surgical steps of image-guided surgery with Callisto assisted, where we have transported the entire data from IL-Master 700 to our microscope. And this alignment, incision alignment, gives you a true assessment of your surgically induced astigmatism. And rhexis can be well controlled within the desired size, shape by the the rhexis marker. Subsequent surgery is simpler as per your choice. You can use any machine, any method for getting a best correction, best removal of cataract possible. Once we do a total aspiration of corticals, lens is implanted, and it's very important to remove the viscoelastic from anterior to the lens or from posterior to the lens also. And make sure your posterior capsule is absolutely clean, because that's going to decrease the fibrotic membrane formation sometimes. Make sure your IOL toric marks are little anti-clockwise, leave anti-clockwise, so that rotation can be done simply into the right area. So this is how our surgery becomes simpler and accuracy becomes much better with image-guided surgeries as such. And if you look into accuracy of image-guided system with the manual marking, you can see manual marking is far away than which we can see with image-guided. So I have adjusted my manual marking by going away from the original mark, and that was well aligned with the image guided system. So this type of deviation can be there in manual surgeries also. If you compare your digital surgery with manual surgery, we know that digital surgery will give you a better alignment, and the results will be definitely better in these cases in terms of better contrast sensitivity, better visual acuity, and quality of vision in terms of point spread function will be far better with the digital mark surgery as such. And if you look into other devices which can also assist in a femtosecond laser assisted surgeries also. And now we have an entire workflow is become simplified by off microscope surgery, where you have a large screen which gives you a high magnification, better resolution, and better contrast for yourself making good surgery, and your assistants can also have a similar view, 3D view, and their learning will be much simpler. And if you look into various systems which are available, they all give you a good video output, high magnification like this. You can assess every point of concern for a cataract surgery. It can give you a digital assessment. It gives you OCT assessment, especially important for intumescent white cataracts. In case of post-polar cataracts, you can classify on table. You can modify your surgical steps on table assets. Patient with highly sensitive to light, you can decrease the illumination light. This is 36% by illumination now. Patient was not able to open the eyes. I will decrease my illumination to almost 5%. And with that also your surgery doesn't get hampered. You can see I'm decreasing my light illumination 5%. Patient can see, but your visualization doesn't get hampered. That's the beauty of this off microscope surgery, gives you access so beautifully. In terms of toric alignment, because of high magnification, your three lines become narrower. So your alignment of toric lens is going to be much more accurate than normal microscope view as such. I think in a COVID era, off microsurgery is really helpful. You're away from the patient point of view. Your distance from patient eye and yourself is far away, and your assistant can sit far away and see the same surgery. And it's been a wonderful apparatus during the COVID time also. There's a little bit of a learning curve initially, but you get used to the surgery. And in fact, once you do a off microscope surgery with the digital 3D microscope, it's sometimes very difficult to go back to a microscope as such. So post-op, I think a toric alignment can be judged by eye trace, which gives you a good assessment of how much rotation is required, what is the visual acuity of a patient, and subsequently you can rotate the lens to achieve a good outcome. So this patient required a large rotation, and this rotation would give you almost 3 dioptric change, and this is a patient which will get benefit after surgery. So this is after rotation. You can say no more rotation will be required as such. So you can have various software which can be used for assessment in terms of how much toricity of lens can be rotated, how much achievement you can get. To summarize the entire talk, I know that manual methods are not very superior to image guided system for a better visual quality and outcome. We know, and it's been a, I think, mandatory part for people who are doing a premium IOL surgery to have an image guided system with them. Interoperatively, if you have aberrometries like aura system, may help you in assessing your toric owl power and its alignment, especially in a post refractive surgery, a post RK patient, where you had a difficulty in getting topographic or a tomographic calculation of corneal toricity power. And in terms of 3D heads-up display, it's beneficial to surgeon, definitely enhance ergonomics, better display, and better overlay system, especially for OCT and toric overlays, much better. For residents, training-wise, is far better. I understand in future, most surgery will be a 3D heads-up display. And I know that many more companies are going to come. The cost will go down, and it will have a more effective utilization of surgical time also. Maybe little difficult for nursing staff because lights may be put in a dim light condition. Sometimes IOL loading and can be difficult with the staff. So that part has to be adjusted, and their distance from the tilt of a screen may be little different for a nursing staff than the surgeon, and it takes some time to get used to that. To summarize, I think markerless digital workflow for cataract surgery is to be there to enhance your surgical outcome, both in pre-op, intra-op way, and in a post-op period also. Anything which can give you a better assessment, right? For toric assessment by ILMaster 700, added by ray tracing aberrometry, integrated image guided surgery, IOCT and aberrometry intraoperatively, and subsequently assessing your patient post-op with eye trace will give you a definite advantage of all premium IOL surgeries. I think we need to have a good workflow for your cataract surgery and the better time saving and effective use of an entire surgical atmosphere. Thank you for your kind